I'm gonna be your MC for the webinar. I will ask Dwight and Mark questions, and then we will let the conversation flow. I am the CEO and co-founder of Flatlight Software. We do AI-powered data analytics focused on stars, and I'm very excited you're here. So to start off with, today is a pretty important day. We finished Plan Preview 1 not that long ago. And Plan Preview 2 with the data will be out later today. With that, I was wondering, Mark and Dwight, if we can start off with maybe some highlights of what we've learned from Plan Preview 1 and if there's anything you would recommend people pay attention to even more in Plan Preview 2.
Yeah, let me jump in real quick and then I'll hand it off to Dwight. But, in working with our clients in Plan Preview 1, it's very clear that you always have to pay attention to the data and compare it to what you're seeing. Clearly, CMS runs a great operation, but it does make mistakes. And calling these out can really make a difference in a measure's value, in the rating, ultimately in Plan Preview 2, and perhaps even in your summary or overall rating. So we're seeing this every day with our clients when we look at Plan Preview 1. I think the second important point is don't be afraid to appeal or raise issues with CMS because the discrepancies in data or things you disagree on are important. CMS respects that. You should be very professional and you should call out why you think it's wrong and things like that. It's hard to oftentimes push back on the entity that feeds you, so to speak, but CMS will listen, and we've seen victories with our clients in appeals. It's happened on call center, on CTMs, appeals, even on drug measure calculations. So, and even on disaster, this year has had an impact even in the LA wildfire case. So, just those two quick recommendations before we get going.
Thank you, Mark. Dwight, any wisdom and reflections from you?
Yeah, I mean, this is the moment where we get our grades, right? This is the final exam already was done, and now we get the grades and we can contest if that paper was graded correctly. I think the point I'd like to make is what CMS responds to is corrections to data errors. So did they do the math incorrectly? Did you have underlying data issues, particularly from the CMS calculated measures? This is not a time to self-report data issues on your behalf because any data valid issues on self-reported plan measures like HEDIS or other measures that like case management measure, those can't be contested from a valid data problem because those were things that you reported and then it would be a 1-star rated measure. So yeah, focus on data. I know there will be celebrations tonight and plans to be frustrated, but yeah, I would suggest you focus on what that's capability of and hope, I'm looking forward today to talk about current year performance.
Thank you. Thank you, both of you. Talking about the current year, I would just like to remind everyone that we have 4 more months left in the year. So that means almost a third of the year is still left. That is a lot of time to make, some significant dent into your star scores. And that's where we're going to start. Before I get into like really like measure specific questions, Dwight and Mark, are there any themes or general like mindset you would like to recommend everybody to get into? This time I'll start with you, Dwight.
Yeah, I think being with where we are today, I think there's a lot of data that early on in the season, even halfway through, you're waiting for claims lag, you're waiting for data to come through. You don't have many half the year appeals have come through. We're now at a point that you have a lot of clear information about where you're performing, particularly if you're comparing yourself to the same time last year. So you have to take an honest look at your scores. And what the Plan Preview 2 will do is you'll update your cut points based on that, but also add room for growth and expectation that everyone's going to improve next year or this measurement year 25. So set the right targets and then work towards those things that here's why I'm saying this. Plans too often will say, well, I have this intervention strategy. I hired a vendor to do that, or I'm doing like if the numbers aren't where they need to be, like if you need a 5-point improvement and your year-to-date score isn't 5 points higher or more, you're not on track. An adjustment is needed. And so, yeah, I've always said how much I hated fourth quarter push. It's just the reliance on that because it's very successful. So I would just say the theme for me and the effort you want to make now is adjust, re-examine. If it's not enough, you have to recognize that the score is not on track and the data doesn't lie.
Thank you, Dwight.
Great.
Mark.
Yeah, just to underscore a couple quick things that Dwight said, I sort of think about it as it's the time for diligence, right? And it's really the time for smart investments. So you have to sort of really look at the data. Where can you move? And clearly, in the last third or the last quarter of the year, you can make changes, but it's got to be very oriented towards smart investment and being very diligent in the remainder of the year.
Thank you, Mark. My first like more tactical question is for you, Dwight. You and I are actually all of us here are probably data nerds in one way or another. Um,
Guilty.
you and I have many times talked about how good data and precision is helpful, especially around now. Um, what are some of your like really specific recommendations for plan in terms of data validation pertinent to this particular time frame?
So yeah, I used to run a national program for HEDIS reporting for like 25 states. And what I learned with my team and my IT support team with HEDIS and other projects was like even for yourself, like data improvement is an improvement. Whether it's not just like get out there and get more interventions, like you can see improvements in your scores by ensuring that you're gathering all the right information. So I would just say is that, you know, we've done this before where you like self-examine your HEDIS data, third-party reviews of your HEDIS data. Then look at, there's a difference between your plan reported information and your CMS reported data. So I think we'll talk about medication adherence and the measures for that, but you're going to want to check and quantify that CMS is actually calculating your appeals correctly and actually classifying them correctly, and disenrollment flags are correct, and the CAI flags for LIS, and like there's a myriad of data elements that if you make small incremental improvements, you actually see score improvements. And I would say is that this has to be like 50% of the effort, which is, well, we have a great HEDIS team. Great, I had a great HEDIS team. I did a great job as a HEDIS team, and we found data errors every year. They were just different things. Like last year we fixed eye exam data. This year we have a problem with the pharmacy data, or all of a sudden our lab data is not matching. Like the re-examination of performance on data quality is something you have to do year-round, ongoing. The more you can do that, the higher scores you'll have.
Excellent. Fixing data errors can give you star scores. I'm going to remember that.
Yeah.
So thank you for teeing up Mark for the drug measures. Mark, you are extremely passionate about ensuring people get their medication correct all the time, and you're very passionate about also like helping plans get the medication to the right folks at the right time. Could you speak a bit about like what are some of the things people can do for drug measures in the last 4 months of the year, which are good for the plan and also good for the members?
Great, thanks, Neetu. So just really, really quickly, just a broad overview. Drug measures are perhaps the biggest challenge for plans out there globally, right? We're looking at drug measures in STAR year 25 in the high twos to the low threes. And that is one reason we've seen eroding overall STAR performance and generally performance well below 4. Although it's about a third of the measures, if you're performing that poorly, you really can't get to high performing, right? So what's more, in measure year 25, we have two brand new measures out there, COB and poly ACH. These guys are tough measures, right? And in essence, we've sort of stratified drug measures into three categories in my mind. And they have different ways of approaching each one of them. Med adherence is a day-to-day blocking type of thing that you have to do for those three med adherence measures. The statin measures are very problematic. You would think they're fairly simple to do, get on a statin, right? But there are problematic issues related to performance on statins as well, and they tend to underperform like the others. And now you have the poly ACH and COB. And those are very, very tough measures to perform on. Often by the time you get the data, they're already in the numerator as non-compliant. and you've sort of lost those members. So very, very complex in drug measures. I think in the closing months, I think on the med adherence side, there are still opportunities to focus in on your folks that are close to 80. They can be slightly below, they can be slightly above, but clearly focus on those members because those are the ones that are most likely going to maintain a rating or improve it along the way. On the statin measures, I do think there are ability to influence these by really getting with your providers and really looking seriously at why somebody is or isn't on a statin, if they have diabetes or cardiovascular disease. I think many providers still don't understand the moderate and high requirement in the SPC measure. So doing some education on that as well could be very, very good, not only for 25's balance, but going into the future. And on the new COB and polys, let me just say, I think you should really look at a risk-based approach. Again, many of your folks may already be in that numerator because of that low amount of time of duplicate therapy. But if you start to think about how to identify those at risk of getting into that non-compliant numerator, so to speak, that is probably a good thing to do in the balance. Later on, I'll probably talk a little more about how you set yourself up on COB and poly-ACH for 26. But I think that's sort of, I'll end there in terms of, proposals on drugs.
Thank you, Mark. Um, um, Before I ask Dwight you another question, I would just like to remind all the participants that you're welcome to start asking questions in the chat, and we will cover them as the conversation is going on. So please feel free to just start recording or asking any questions that come to mind. Happy to have them. Would love for this to
Good.
be more of a conversation. Thank you, Mark. With that, Dwight, I'm gonna go to you next. For as long as I have known you, you have talked about CAPS and Haas, and you have talked about how Haas is even more important now than it has been in the past. Could you speak a bit more about CAPS and Haas and how plans can influence those measures and connect with members?
Yeah. So I have about 2 hours to answer that question, right?
Yes, yes, you of
Okay,
course
good.
have 2 hours.
So you can hear me ad nauseum talk about these topics. Let me start with Haas, and I'm really focused not on the 3 1-weighted measures, which everyone fights to get sort of interpretation of how members would recognize that they got influence around activities or continence and the like. But the 2 new measures, or they're not really new, returning measures after several years, are going to be 3-weighted. Well, they're already here. The survey's going on right now. So what you have is it's going to go until November. You've got still 2 months, right? So I would suggest, even if you've done nothing, starting tomorrow, I would suggest you focus on promoting the survey and increasing response rates. I don't really have that much time to talk about it. It will help your scores long term to have a larger pool of members respond to your results. It will also create stability in your scores. And this is the members that are surveyed now are going to get surveyed 2 years from now. So if you have a larger sample size now, you're going to have a larger pool of members in the future. It creates better results. Something to talk about another day. Haas, from an intervention strategy, is those 3-weighted measures. It asks members things like activities of daily living, depression, social isolation, and whether their experience now, how they rate their experience, and whether it's affecting their life. And then 2 years later, we ask them again the same questions. And it just compares. If they're the same, it could be negative, but as long as it's the same or better, then your score does well. So what you're trying to identify is members who have changes in mental health, experience, social isolation, activities of daily living. So you can use data and analytics to identify those members. You can do AI interventions, strategies, but you're going to have to do population-based work. It's all your members. Any member is at risk for changes in experience and health status at any time. This is a 9 to 12-month project. You need to engage in a strategy for next year's survey collection. So after you deal with just improving the survey, I would recommend you also focus now on how do I identify the members and how do I help them. I would suggest just focus on depression or sadness and use different ways to identify that and find social services and activities that you can help address them. I know I'm taking too long. CAP survey, really quick. We could talk about it for years. There's many things to do. My one takeaway today would be this. It is not one monolithic question, and that means it's not one monolithic solution. What I hear from plans is like, well, I do a reminder and you want to increase response rates. But this is assessment of questions around access and availability of your network, care coordination, which does not mean did your doctor coordinate care. It's elements of what your doctor's behavior is. It's going to ask rating of drug plan. It's going to ask rating of health plan, customer service, filling out forms. How many times do you fill out forms? Who those people are. We're talking about 10 different projects. So think of it as just as different as eye exam is for medication adherence. CAPS is a series of topics you have to address individually. You have 6 to 9 months to impact this. There's tons you can do. Success is coming. There is no reason you couldn't have a better score next year.
Thank you, Dwight. We have a follow-on question from the audience. How do you recommend we promote HOS survey responses compliantly?
So they don't want you to show surveys to anyone, like here's what the survey looked like. The idea is you tell everybody, you don't know who's in the survey, right? So when it's survey responses, you're really just promoting it. So if they call into customer service, that might be a recording that say, hey, you're getting another survey with the government, but this is critical because it's your clinical care. Before you end a call, it's like, hey, by the way, you might have been selected as a subset of a sample of members to get a survey. It's called this. Here's what you might get. We encourage you to fill that out. Like, you're allowed to promote the survey. You're not allowed to tell people how to respond or what its influence is financially to you. So go back and look at the specification. It tells you that. But I would encourage you to just remind people. People have been doing this for CAPS for so long, they're used to it, right? It's built into their customer service practice. But every member engagement is an opportunity to remind them that this survey's been out. If you saw it, please fill it out. Because members don't know that if they got a CAPS survey, now they get a different survey, the provider sends them a survey, they might get confused or, I already filled that out. No, this is a new one. So there's ways to promote that across your population.
Yep. Thank you, Dwight. And Lynn, if you have a follow-on question, please just add it.
Sure.
I'm gonna actually there's another CAPS question, so I'll ask that one first. What are 1 or 2 specific CAPS initiatives you've seen have had the biggest impact in moving the needle?
Yeah, I once went to an actual webinar for another plan, and this is what they did. They showed a study where they just contacted, instead of doing a 30-question survey to a small subsample, they asked 3 to 5 questions of almost everyone in the plan. You can do this through, agentic outreach. You can do it automated calls, whatever. So they gathered as many people, and anyone who rated the health plan below a 5 or whatever, they called them over the summer, starting in August, but they didn't say, hey, you rated us poorly. They said, hi, we're here to, we're from your health plan. We want to make sure you're getting the services you need and that you're satisfied. How can we help you today? And then the member said, hey, I have a problem getting an appointment with this specialist, or I have a problem here. And they resolved their problems over the 3 to 6 month period, and scores went up. And the reason I say that is, like, we often want to play those things where it's like, well, we promote the survey more, or we address, dissatisfiers. But I like the idea of like finding the unengaged, the middle rated person, not the most unhappy person. You're going to have more people that are like, yeah, you're pretty good. That think an 8 out of 10 is good, but 8 out of 10 for CAPS star rating is actually poor. So that's my take. I think that you can imagine there's some other strategies that identify that, but it is not just identifying the poorest, saddest person of those, most dissatisfied. It's the average rated, the unengaged, the lack of provider experience that fill out the surveys too. And I would encourage you to think about finding those members and assisting them. Yeah.
Yeah. Thank you, Dwight. And I want to reinforce the plug for actually being able to use voice agents to do these phone calls. They're very administrative, they can be short, and they are very cost effective at scale. So that's
Yeah, so I want to say that as a follow-up, like, classically, we say we're going to do a survey of members, and members are burdened by surveys, too many surveys, they don't like filling out surveys. Don't do a survey. an AI tool can have a conversation with the members, say, we're checking in. Do you have any questions on your benefits? Do we need to refer you to assistance? And they can ask one question, and it can be random, right? It could be like, well, I'm going to ask these members about access. I'm going to ask these members about pharmacy, whatever. You can learn about what your members feel and describe it. But that AI is a little bit better at collecting information and analyzing what members are saying.
Yeah.
And let me tell you, there are new features where you can listen to a 1 minute, vendors that record a 1 minute recording of the member and say, these members are depressed, right? There's a lot out there. I encourage you to be creative and in using tools that will help you engage members in a way that you've never done before, that gathers better information so that you can serve the individuals that actually need help.
Caps and Haas is a popular topic. We have another question on
I
Haas.
told you we could do 2 hours on this subject, but we'll see.
We may have to cut it off before 2 hours, but
Okay.
but have you seen any benefits to Haas oversampling?
Yeah, so I'm a huge believer in oversampling for the purposes of Haas, because if you understand the way that those three weighted measures work, they take a random sample now, and it's pretty large. It's like 1,200. If you look down to like how many people fill out the survey and how many you end up with, it's pretty small. And then what happens is they want to resurvey members 2 years from now. So some members unfortunately die, others leave your health plan. So they have to now 2 years later be in your health plan and had been part of the sample of surveys and responded to the survey. So what happens is your response pool of members shrinks the second year, 2 years from now. And then it's really small because not all of those people will fill out the survey the second time. So then you're getting a very small response rate that statistically is not that strong. So then you get a lot of variability in results. And if you look at Haas results from plan to plan, there's lots of more up and down in scores, and it's often based on sampling. So oversample is an expensive endeavor, but it can protect you from those variabilities and problems of having too small a members responding.
Thank you, Dwight. Thank you, Dwight. Um,
Yeah.
If anyone has follow-up questions, please just ask them. But I now have a question from the audience for you, Mark, on the drug measures. SGLT2 inhibitors in patients with CHF is negatively impacting our DM, I guess, drug measure adherence. Do you have any ideas on that?
And I'll ask Dwight to weigh in here too. We are aware of a number of drugs out there that potentially bring people into a measure, right? And unfortunately, the way the measure is structured, you really can't do anything about that, right? And what we recommend there is that you sort of look at these types of drugs that appear to be impacting the measure and really catalog them and engage with CMS and PQA about those drugs, right? There's, unfortunately, if you're qualified in the drug measure with certain drugs based on the way it works, that is sort of what it is. But I think over time, as we look at the nature of certain drugs, encouraging PQA and CMS by telling them those kind of things is very important. I don't have any silver bullet right away to deal with that issue. Dwight, I'll hand it off to you, but I think we've talked about this in the past as well.
No, we have talked about this. You can't take them out of the measure, which is what you want, right? So long term, what Mark's saying is we have to influence those that create the measure to find out ways to exclude them, because it's inappropriate to put them in the same measure set, because we're not using, they want to use pharmacy data as the denominator identifier, not diagnoses. But we do know that these medications are forcing doctors, let's say it, we're correct. Doctors are potentially putting in diagnoses that then validate the medication, which then would put them in the measure anyway, right? There's some weird stuff going on out there. So I would just suggest, this is my first level take, is everybody has to deal with this. So in my head, I think, okay, the playing field is evened. Not exactly, because plans might have different types of members, but we're all in it. So the measure ratings have a ceiling effect. There's a whole bunch of members in everyone's measure that they can't actually address in the same way. So you might think about ways to like recognize and focus on the members you have an influence on, and maybe the cut points change as those, as everybody's influenced. That's my anticipation.
Thank you. Yeah. Mark, were you going to add anything?
No. I think that's exactly right, right?
Yeah.
You can't over fixate in any given year about those kind of things. Document them, force
Yeah.
change with your groups, and focus where you need to. Yeah.
The more evidence you have on a mathematical formula to say, now we're at 20% inappropriate members in this measure, CMS, you need to throw this measure out
Yeah.
or fix it, right? The feedback has to go pretty strongly from everyone to CMS and others to say, this measure is screwed up now. You need to find a way to fix it, as opposed to just putting us into a measure that's inappropriate. And they have removed measures, fixed measures, adjusted them as changes in services happen that affect the measure's quality.
Sounds
And to me, that goes a little bit into the bailiwick of reconcile your data between CMS and plan. So you're not going to be able to take care of this one issue we're talking about in a given year, but build it into that process, document it for the long term, and then also recognize that calculations from CMS and the plan may be different, and go after those as well. So treat it within that gamut and separate it out. Long-term influence versus what data do you really need to change in the current year.
Sounds good. We have one more CAPS question, which I will hold till the end. And we'll come back to that question after a few more topics that we discussed. So whoever that is, thank you for the question. I'll get back to it in just a little bit. So moving on to slightly different measure. Mark, you are the country's foremost expert on SNP and DSNP plans. And I was wondering if you could talk to our attendees about HRAs. We probably have several people in the audience who are probably trying to figure out, looking at their like vast amount of HRAs and reassessments that they have to do this year and wondering how they're going to be able to catch up this year or impact next year.
Great, Neetu. Yeah, I think it's a great question for a number of different reasons. The HRAs and that one SNP measure is where STARS meets growth strategies, meets outcomes and other measures, and things like that. We see so much going on with growth of special needs plans. I track enrollment every month, and we have seen not only the benefit investment for 25 in SNPs increased dramatically, whereas benefit designs and terminations of mainstream MA sort of declined, right? But SNP investment in benefits and new geographies was great. And the enrollment growth is phenomenal. We're now almost at 25% of all MA members being in a SNP, just short of that. And more importantly, the growth is phenomenal. I think in this year alone, it's been 500,000 members, or now probably close to 600,000 since the open enrollment season ended. And so that's a huge issue for plans, because we generally see many plans having very poor performance on this measure. And what they perhaps don't realize is, as the program audit regime continues to mature for SNP and SNP mock, that's going to really impact your performance on audit. So audits and STAR also sort of go together in that way. And what I think many people don't realize is, if you miss an individual, you have a chance to catch up if you miss your initial. You don't get credit in the initial, but you do get credit if you do it within 365 days on annual. So there is sort of a catch up without penalty, so to speak. There is a penalty on initial, but you get to credit yourself on annual. But if you're consistently missing people on a reassessment, you actually need to get 2 HRAs done after you are late in order to requalify that member, or that member continues to count against you in the formula. And I would also note that HRAs, from a clinical standpoint in the SNP world, is really the foundation of good care management and performance improvement. These folks are the guys and gals with social determinants of health barriers, and you learn a lot from that health risk assessment. You're now mandated to look at SDOH barriers, and you can look at the multiple comorbidities and craft good care plans in order to do that. And we know care plans are part of that audit protocol as well. I think there's a couple of things that plans need to do here. Careful tracking on the status of all your members with assessments are critical. Some systems do that, but not all of them. Trigger lists of what's due in 30, 60, or 90 days from a due date that you establish are key. I think forecasting where you're going to end up performing is also very essential. You can use year to date on what you've done. You can forecast remaining years against your historic completion rate and get a pretty good understanding of it. If your SNP is growing tremendously, you need to really think about the impact to your numerator and denominator as your enrollment grows. We're seeing some SNPs grow 2 and 3% by month, and that's huge because the number of people that are being added on a gross and maybe a net basis to your plan is very, very big. I would also employ a labor calculator. And that labor calculator would basically say, how many FTE equivalents do I need in a given month to perform assessments? And usually overtime supplements your assessment performance. So what do you need in terms of overtime as well? And that's a good diligent way of getting your executive staff to say, yes, we have to invest in this area. You're planning well and you're trying to achieve greater star scores, and they're more likely to give you some of those dollars or potentially not chop away at your dollars for staff and overtime in this really trying time for admin and things like that. And let me go back to one last thing. I think agentic AI can give you a great boost out of this. We believe that you can use agentic for outreach as well as conducting HRAs, and I think you can be compliant with CMS requirements. We do have some questions into CMS exactly on this to get some clarifications, but we know people are out there are using it. We believe you can do it compliantly, and that may be an answer, a combined real staff and agentic approach to performing well on SNP measures, getting HRA completions up, getting compliant on care plans, and really driving better performance and reducing costs for these individuals.
Thank you, Mark. Everyone, keep the questions coming. I will get to them as we're progressing in this conversation. I'll just try to make them relevant to the time that we're having the conversations. Otherwise, I will ask them at the end.
Me too. I just want to have an idea on the HRA. Plans
Yeah.
are struggling with reaching members.
Oh, yes.
Yep.
So we need to start being creative on who has the right connections to the members. We talked about years ago, we talked a lot more about how brokers can influence the members' participation in things. Providers, like in the future, you could literally, I saw years ago a plan incentivized the office staff to do things, and they rewarded and paid bonuses to the front office staff of provider groups. Now, these are relationships you have to work out, but think about the idea that members are going to providers, and if those staff could like distribute HRAs and get incentivized to do so, maybe you don't do a reward individually, maybe like the office with the most HRAs completed gets a couple lunches or whatever, things like that. But start being creative to find and reach members, because the phone is, AI is going to help that, but like phone calls is not working. So you're going to have to start doing more and more. We can talk about it another time.
Yeah, I think it's a great point, Dwight. We've seen on audits that provider HRAs count, right? They have to match the domains that you have to hit, but they can count, leverage those. And from an outreach standpoint, many plans are doing 3 and done, because that's sort of what the requirement is, right? You need probably 10 outreaches if you can't find somebody before you get that person. So that's where agentic could come in here, right? You could combine agentic and staff outreach to get to members, but you're never going to have a healthy HRA rate, whether it's STAR or just for program audit, unless you think about different days, different times, and increasing the number of outreaches you do.
That's excellent. Mark, I'm going to stick with you for the next question as well. You are passionate about many things about healthcare. And another one here is about complex clinical care for members. So that's specifically the PCR, TRC, and FMC measures. Those measures have traditionally been like very, very difficult for plans to get to a higher star rating. Do you have any recommendations for our audience?
Yeah, absolutely. I think it's a great point. I think similar to the drug measures, while there are fewer of these, but these, what I call event-based measures, are very tough. And your PCR measure is now three-weighted. And so they do count a great deal, right? And I believe that holistically, the PCR, FMC, and TRC measures actually influence overall performance and they impact cost of care, right? So this is where all the overlap occurs. And big struggles on all of these, right? And a couple of thoughts on this. Number one, our research and our data shows that these three measures are interrelated, and the relationship between your performance on TRC and PCR is very strong. So you almost have to attack all of these together. Many people will go out and say, let me try and impact PCR because it's three-weighted. But if you're doing poorly on TRC, as a good example, you really need to attack them together. So number one, think about a holistic approach. I think number two, you also have to really do a combination of retrospective deep data review on all of these measures, as well as proactive strategies to get discharge notification, admission notification, and ED notification into both the plan and the provider, because that's key. That's what's going to drive your patient engagement in MedRecon, and that will also set up better care coordination and care transitions for your readmission measures, right? And I talked about TRC, and that engagement ties very closely to PCR. On PCR specifically, we've done a lot of work on this, and the deep dive would show that if you can apply the measure calculation at a provider group level and try and come up with observed counts and expected counts by provider, you can learn a lot about where your real problems are. And what we find is that a small number of large volume groups, as an example, can really disproportionately affect how you're doing on that PCR measure. On TRC, we are also noticing a lot of trends where people just perform poorly on admission notification and discharge notification. You got to get ADTs coming into your plan, and you got to plot that long-term strategy. But number two, we're seeing a fall off between patient engagement performance on the submeasures in MedRecon. There's probably some folks that are not performing the MedRecon, even if they are doing the patient engagement, but more often than not, they are probably doing that MedRecon, but they're not coding it properly and reporting it in. So those are sort of how all of these measures really interrelate. And strategic investment here, setting up a committee that's looking about all of these things, retroactive reviews and ongoing strategies for ADTs are the only way you're going to get consistent performance on these measures.
Thank you, Mark. Dwight, I'm gonna go to you next. Keeping with the theme of you and I being like serious geeks. I think that's a good thing, by the way. I
Okay,
think
good.
I wear my geek pride flag very, very happily. Um, you've talked about MathPath. We sometimes call it precision analysis, but basically STARS is a game of inches. So could you share some of your thoughts on using MathPath for better STAR scores?
Yeah, I mean, I think too many plans miss a number by a little bit. They're a 3, 5, they want to be a 4, and if it's only these things. And I think there's precision in putting the right efforts and interventions to the right people, as opposed to like MathPath being like, you have to know you're going to hit your target overall, which is a 4-star, 5-star, whatever. And that's a whole strategy that we can work through. But the precision that I really want to focus on is just we have limited resources and time. We need better analytics. And one of the things I have fun with Lilac doing is working with them on their analytic programs and tools so that they can better streamline and get to the right people. And I think that's what you want to focus on is we're going to have to do less with specific people with better success. And so you have to not just globally give everyone the same intervention, and data is going to help drive that.
Thank you. Thank you,
Thanks.
Dwight. We have a few more questions that I'm gonna ask next, but before I ask those questions, I just want to remind everyone that we have a survey that is an anonymous survey that we would very much like for you to fill out. It'll help us and learn more about like what's interesting, what's maybe we should spend more time on, and if you have any suggestions for new sets of topics that we should bring to this audience. So please take a few minutes and fill out the survey. It will help us a lot, and we appreciate it. Going to the set of questions, maybe I'll stick with you, Dwight, first. So, what would be the top three problems you think a population health vendor could help health plans to perform better on star rating?
Well, first and foremost, when you mention the word population health, I think plans are very good at like developing like a case management program with a set of 4 people doing calls. Like they're not as good at like globally addressing projects that have to address so many members. So population health programs, whether they're in-house or vendors, can are the scope that you need to build. Like it affects caps. There's lots of measures that they're either now or in the future expected to put into stars that are all members in your plan, like cost questions, right? So do you need better analytics to like identify who's the challenge or what needs intervention, and then programs the vendors can support to do that analysis, but also then deciding and helping do the work, right? Because the plans are often limited in the right resources. So if you have an expertise in how to reach members, have resources to actually do it, I think plans all need that kind of work.
That's great.
Hey,
Thank
Nitu, can I use that as a
Yes, please.
quick entree? Because there was one point on PCR that I didn't talk about, and it goes to the issue of data. We spent a lot of time talking about how look at your providers and how they're performing through the deep dive, right? But we've also done some very good research, and I think this is applicable to all these measures and across all plans, that there's also a plan opportunity to address, obviously, TRC and PCR, but specifically on PCR. Look at the diagnoses generating your readmissions. And what we find is there's actually 2 categories. One is well-known, inadequacy of plan disease management and case management approaches to disease states. In particular, we've seen CHF and other heart-related disease and diabetes. Those are 2 big generators of readmission. And so you can directly intervene through care transitions as well as disease and case management on those. We're also seeing potentially some hospital-acquired type conditions like sepsis and things like that. And if they're not hospital acquired, they may occur because of poor post-discharge care and things like that. So look at your diagnoses in that realm, because there's a diagnosis or disease state approach here too that can supplement your look at the provider data.
Thank you, Mark. On the medication adherence front, Mark, maybe sticking with you, how much would it help if I have a provider access a dashboard or a report with members that have not filled their medication on time?
I think it's really important. One of the things in terms of poor performance on drug measures that we see is many plans are relying exclusively on CMS Acumen. And without going into the details, that gives you a 90 to 120-day lag, generally speaking, in terms of the data you're acting on. Even if your PBM is sort of filling in part of the void, there's still a substantial delay. And so, for example, Lilac will essentially use their PQA engine to run real-time data through, so we can give you up-to-date daily refill lists and overdue lists for med adherence and weekly lists to act. And I think providers need the most actionable, fresh data through a dashboard, through reports, through chase lists, whatever that mechanism is, to really drive performance on all of these measures, right? On the COB and poly-ACH, it's more of a dialogue between the plan pharmacists and perhaps multiple prescribers of a member to deal with, and a risk approach there. And on the statin, I mentioned plans having to educate providers on some of the statin issues and things like that.
Thank you, Mark. We have one more question that I want to follow up on, and then the CAPS question we'll write up an answer for. What recommendation do you have around folks who are in a long-term care facility or an assisted living facility where they're finding that the members will fill twice, maybe a 7 or 14-day supply, but then are locked in and they are appropriately have the medication stopped in the facility?
Big, big issue. And again, I don't have an immediate perfect response here, right? I know that we are changing many of these med adherence measures. So you're moving from what we have today with adjustments from medical claims, sort of boosting your performance rate because you get credit. And I would note that even we still have that, so you should really focus in on that, because that oftentimes there's disparity between what CMS Acumen says and what your plan might say. And sometimes it's even related to plan problems with encounter acceptance and things like that. But number two, this is one of the areas where we're going into a brave new world. We're now going to risk-adjusted med adherence measures without these adjustments. And so that is a big change and transition for plans. And I think there are a whole bunch of things that impact rates. So we had the earlier one on certain prescriptions that may or may not really mean somebody should be in a denominator, but they're put in there. And then we're always going to have this issue of care transitions and when somebody gets a drug from a long-term care facility or assisted living and things like that, that certainly impact your performance. I would go back and say document these two, because these are things that plans need to come together on and sort of explain to PQA and explain to CMS why you're still not being rated correctly on your drug measure. But I'll turn it over to Dwight because I know he's looked at this as well.
Yeah, I would say in adherence, there's so much low-hanging fruit conceptually, where you've got lots of members who are just like missing fills, and you track the number of days and how many can be converted. If you looked at your population and this long-term care facility, ALFs, are doing something you can work with, and it's enough member, like if it's one member, the workload is not worth the squeeze unless you have this very small denominator. Like, so it's not that you don't care, but where are you going to get your success? So if you had enough members at an assisted living, my father's at an assisted living, so I've learned a lot about this stuff lately. So I would suggest you understand this, like there's usually one doctor that sees everybody. There's a nurse on staff that leads the med support, right? So it's not like you have to work with lots of people. So if you happen to have a lot of long-term care members in a specific facility, it's not like you have to work with hundreds of people, one member by one member. But if it's one member per facility and are all over, like you're going to be running yourself ragged trying to address why one thing happened or another per member. And I think your better success is, population-based programs that get at a larger set of members. But yeah, if it's sizable, it's going to change your scores. The effort is going to be convertible for multiple measures in the future. You can identify clinicians in those settings. This is the same for all other services, trying to get them flu shots, arranging other services. If you have a lot of members and sending this at smaller plans at a specific place, you can create a relationship just like you would with a provider, and they'll be happy to work with you on getting services done.
Yeah, and I think, Dwight, that's a great point. And looking at who your member is assigned to often is very important, because this is a good example of who's really primarily taking care of the individual. There's a lot of attributed providers based on claims data versus maybe who's actually being assigned.
Thank you, Mark and Dwight. We still have a couple of questions that are unanswered. As Alex mentioned, we will answer them in email in written form to back to all of you. If you have more questions, you can still leave questions for us. But I just want to thank Mark and Dwight for rapid fire questioning and also for like, sharing their wisdom. And thank you to our audience for being here and spending a whole hour with us. Good luck to all of you for Plan Preview 2. If you need help, reach out.
Thank you, everyone.
Great.
Thank
Thank
you.
you so much.